second part of the discussion on hydroxychloroquine, and this is the rationale behind its use in COVID-19. Yes, there is hypothesis that chloroquine, an amine acidotropic form of quinine, or hydroxychloroquine, a less toxic 4-aminoquinoline derivative of chloroquine, can reduce mortality in 50% of those cases with severe acute respiratory syndrome infected by the SARS-CoV-2. On 18th of March 2020, Liu et al. In Cell Discovery published an in vitro study on African green monkey kidney VERO-E6 cells, saying that these are weak bases which are known to elevate the pH of acidic intracellular organelles such as endosomes and lysosomes, which are essential for membrane fusion. In addition, chloroquine could inhibit the SARS-CoV entry through changing the glycosylation of the AC receptor and the spike protein. Hydroxychloroquine effectively inhibits the entry step as well as the post-entry stages of SARS-CoV-2. There are a lot of virus host attachment mechanisms, out of which the carbohydrate molecules like sialic acid, which serve as the receptor binding determinants for SARS-CoV-2, are important here in the discussion, because we know that glycoproteins of lipid-enveloped coronaviruses have three important functions. One is to recognize the receptor on the cell surface, to mediate the viral fusion within the cell membrane, and finally to destroy the receptor. Chloroquine inhibits the quinone reductase, which is involved in this sialic acid biosynthesis. So therefore it damages that ligand recognition and therefore makes this agent a broad antiviral agent. Chloroquine also interferes with the post-translational modification of viral proteins. It can be hypothesized that SARS-CoV-2 molecular crosstalk with its target cell can be altered by chloroquine through inhibition of kinases such as MAPK. Chloroquine could also interfere with the proteolytic processing of the M protein and alter virion assembly and budding. High concentration of cytokines are detected in the plasma of critically ill patients infected with SARS-CoV-2, suggesting that this cytokine storm is actually associated with the disease severity, and the quinine group of drugs can help here. The other than direct antiviral activity of hydroxychloroquine is that it is a safe, successful anti-inflammatory agent, and it has been extensively used in autoimmune diseases and can significantly decrease the production of cytokines, in particular the pro-inflammatory factors. And mind you, for people like us, diabetes of course is a pro-inflammatory metabolic state, and whether people with diabetes getting this molecule in order to prevent as prophylactic for COVID-19 is important or not is a debatable matter. Very recently, we have come across these studies, the phase 2b clinical trial Brazilian chloro-COVID-19 study led by Myla Borba, which was published in medRxiv, that shows, there are preliminary findings which show us that the higher dosage of chloroquine, which is almost 12 gram total dose over 10 days in COVID-19, should not be recommended because of the safety regarding the QTc prolongation and the increased lethality in the Brazilian population, as fatality rate was 13.5%, shown here, overlapping with the confidence interval of historical data from similar number of patients not using chloroquine. Although case series have demonstrated a potential benefit in decreasing the upper respiratory viral load, no studies to date have addressed key clinical outcomes such as mortality, effect on escalation of respiratory support, and hematology benefits. The biologically plausible mechanism of action of hydroxychloroquine in SARS-CoV-2 hosts is suppression of the aberrant interferon and the tumor necrosis factor levels responsible for the corollary clinical findings such as lymphopenia and elevated neutrophil to lymphocyte ratio. In fact, on 4th of April 2020, Joshua Barbosa et al. From the United States published that hydroxychloroquine admission with initial loading dose of 400 mg orally bi-daily of off-label hydroxychloroquine for 1 to 2 days, and then 2 to 4 subsequent days of a 200 mg to 400 mg once daily dose to the hospitalized SARS-CoV-2 positive population was associated with an increased need for escalation of respiratory support. There were no benefits of hydroxychloroquine on mortality, lymphopenia, or neutrophil to lymphocyte ratio improvement. In another new study published on the 10th of April 2020, among the 84 patients who took hydroxychloroquine, 20.2% were admitted to the ICCU. It's a French study of 4 hospitals who died within 7 days of taking the drug. Among the 97 patients who did not take the drug, 22% went to the ICCU and died. The difference was not determined to be statistically different. Looking just at deaths, 2.8% of the patients who took hydroxychloroquine died, and 4.6% of the patients who did not take also died. Now, that difference was not found to be statistically significant again. Finally, this goes on to say that these results do not support the effectiveness of HCQ at 600 mg per day, and the use in these patients with documented SARS-CoV-2 positive hypoxic pneumonia who are hospitalized requiring oxygen of more than equal to 2 liters per minute. Now, these 3 news made me cynical, and I started, frankly, wondering that whether the wonder drug hydroxychloroquine actually is good for these cases, or whether it will cast a mirage image on people's expectations on the so-called positive outcomes from COVID-19.